Madam, we are live now. Shall we start the program?
Yes, sir. Shall I start, sir?
Just 1 minute, sir.
Yes. Shall I share the screen?
So, good evening, doctors. I'm Shimon on behalf of Shield Healthcare, welcoming you all in today's program on recurrent vaginal infections, and our guest speaker is Dr. Bhavani, madam. Before moving into the session, let's have a look on our Shield Connect page. Here, this is our Shield Connect page. Here you can find different blogs written by many Indian doctors across India. And these are the past webinars already we have conducted in our platform. You can have a look on this that is available in different by different doctors, and these are the important thing is our key opinion leaders. So presently more than 500 doctors are currently supporting us this knowledge sharing initiative of Shield Healthcare. So now it's time to start the program with Madam, and it's my honor to introduce Madam. Madam is the Assistant Professor, Department of Obstetrics and Gynecology, Law and Trichomonas Vaginitis College, Trichomonas, and Madam Leader in this DG, DNP, and Criminology Training in Service Technology. And as per the area of interest, Madam is very much interested in high risk obstetric management and infertility, and she has also done many research studies, and another one studies is still going on. So, in this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. So, thank you very much, Madam, and over to you, ma'am, for further talk. Thank you.
Yes, sir. Good evening, sir. Good evening, sir. I am Dr. Bhavani. I am working in Government Tiruvannamalai Medical College. Shall I share the screen, sir?
Yes, ma'am. Please share the screen.
Yes, ma'am.
Yes, sir. Can you see the screen, sir?
Yes, ma'am.
Yeah, sure, madam.
Yes. Yes, I am Dr. Bhavani. I am going to talk about recurrent vaginal infections. And in a healthy vaginal flora, lactobacillus species predominate. The lactobacillus species excrete hydrogen peroxide, creating an acidic environment. The low pH acts as a natural disinfectant. The pH in the vagina is 3.5 to 4. The ecosystem in the vagina, due to the presence of estrogen, the vaginal mucosa will be very thick, and it causes increased production of glycogen, causing more lactic acid production. Thereby, the pH decreases to 3.8 to 4. Because of the decreased pH, it promotes the further growth of lactobacilli and inhibits the other pathogenic bacteria. In this slide, you can see in the reproductive age group, due to the presence of high levels of estrogen, the vaginal mucosa is very thick, which causes increased production of glycogen, which is degraded to hydrogen peroxide and lactic acid, causing low pH. Whereas in prepubertal and postmenopausal women, low levels of estrogen causes thin vaginal mucosa, thereby low glycogen content, and therefore lactic acid is also low, causing high pH and pathogenic bacteria proliferate. So, vaginitis is defined as a spectrum of conditions that cause vulvovaginal symptoms such as itching, burning, irritation, and abnormal discharge. The three most common causes of vaginitis are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. The risk factors for vaginitis are poor personal hygiene, obesity, using too much of soap, uncontrolled diabetes, wearing clothes that are too tight, and use of feminine deodorants, and excessive use of antibiotics, stress, frequent change in sexual partners, unprotected sex, pregnancy, inadequate sleep, and poor nutrition. Coming to the first one, bacterial vaginosis, it is a polymicrobial clinical syndrome. It results from replacement of lactobacillus species with high concentrations of anaerobic bacteria. Most women with bacterial vaginosis were asymptomatic. If the symptoms are present, they are homogeneous, thin, white discharge, and a fishy odor of the vaginal discharge. The diagnostic criteria is called Amsel's diagnostic criteria. If 3 out of the 4 symptoms are present, we can diagnose it as bacterial vaginosis. The 4 symptoms or signs are homogeneous, thin, white discharge that coats the vaginal wall, and clue cells, which is nothing but vaginal epithelial cells that are studded with coccobacilli, and the pH of the vaginal fluid more than 4.5, and fishy odor of the discharge before or after the addition of 10% KOH. And other diagnostic criteria is a Gram-Stein criteria, which is called Nugent score. In this, the number of organisms per oil immersion field is seen. If the lactobacillus is high, if the number of lactobacillus is more than 30, the score is very low. It comes to 0. If the number of Gardnerella or Bacteroides is high, the score is given as 4. Finally, when the total score comes to 0 to 3, it is normal. If it is 7 to 10, we diagnose it as bacterial vaginosis. The recurrent bacterial vaginosis is defined as 3 or more episodes in a period of 12 months. The risk factors for frequent recurrent bacterial vaginosis are frequent douching and frequent sexual intercourse without a barrier contraceptive. The three theories are postulated for recurrent bacterial vaginosis. They are intestinal reservoir theory, which suggests that the persistence of the organism in the GIT reinfects the vagina, and sexual transmission theory, in which the sexual partner is the reservoir, and vaginal relapse theory. In this, even with treatment, the organism will remain colonized in the woman. So the treatment for bacterial vaginosis are metronidazole oral or topical, and clindamycin oral or topical, or oral tinidazole. Second most common disease is vulvovaginal candidiasis. It is most often caused by Candida albicans, and non-albicans species causing candidiasis is Candida glabrata. So it is more common among reproductive age group women. It is rare in prepubertal and postmenopausal women. Why it is common in reproductive women is high estrogen levels are thought to make be more susceptible to vulvovaginal candidiasis. Estrogen increases the glycogen content of the vagina, so it has a direct effect on the candidial growth and increases its adherence to the vaginal epithelium. The symptoms is typical white cottage cheese discharge or curdy white discharge, and the inflammation will present as vulval pruritus, burning sensation, and dysuria. Asymptomatic carriage is also present in 20% of the women. Recurrent vulvovaginal candidiasis, it is defined as 4 or more episodes of vulvovaginal candidiasis in a 12-month period. The risk factors are antibiotic abuse, pregnancy, oral contraceptive use, steroid treatment, diabetes, and conditions whichever weakens the immune system. The treatment of vulvovaginal candidiasis are topical nystatin or oral or topical azoles. And we can also use boric acid intravaginal capsules and topical steroid to alleviate the symptoms. So if the management of the vulvovaginal candidiasis is not responsive to the standard treatment, we have to go for the culture. The culture is positive for albicans, we have to prolong the treatment. Either we have to double the course of the pessaries, or we can give suppressive treatment for 6 months. If the culture is positive for non-albicans varieties such as glabrata, we shouldn't use fluconazole, and we have to go for the boric acid pessaries and flucytosine. So the third most common vaginitis is Trichomonas vaginitis. It is caused by Trichomonas vaginalis. The symptoms being greenish or yellowish discharge associated with foul smell, and genital itching, burning, and soreness will be present. Diagnosis is by microscopic examination of the vaginal fluid or NAT. As we all know, treatment is same. Metronidazole 2 gram or tinidazole 2 gram can be given orally, and the cure rate is 90 to 95%. The recurrence in Trichomonas vaginalis is very less, but we have to treat the sex partners, and the patient should be instructed to avoid sex until they and their sex partners are cured. So I have put all the 3 vaginitis in a single slide. In bacterial vaginosis is caused by replacement of the lactobacillus by anaerobic species. Candidiasis is caused by Candida species. Trichomonas is caused by Trichomonas vaginalis. And the main characteristic clinical feature is foul smelling and itching will be present. Both will be present in Trichomonas vaginalis, whereas itching alone is present in candidiasis, and foul smelling discharge alone will be present in bacterial vaginosis. So the current treatment options are antibiotics and antifungals remain the mainstay of therapy, whereas the recurrence rate is high and it is associated with more side effects. So looking into the future, we are using probiotics as an alternative to antibiotics. Probiotics are nothing but live microorganisms, which when administered in adequate amount, they give a benefit to the host. The main types of microbes are lactic acid bacteria and bifidobacteria. Prebiotics are substances in the food that are helpful for the growth of the microorganism. It will stimulate the growth and reproduction of the microflora. It will maintain an optimal pH in the intestine. It will stimulate the local immunity, and it will remove excess mucus from the small intestine. It will reduce the formation of gases, and it will suppress the reproduction in the intestines of pathogenic bacteria. It will stimulate peristalsis, and it will improve the work of the digestive system. The lactobacillus exerts its protective effect by microbial competition for nutrients and for adherence to the vaginal epithelium. It decreases pH by producing lactic acid. It produces antimicrobial substances like bacteriocin and hydrogen peroxide, and it will also cause modulation of the local immune system. And one more product is Lactoferrin. It is a glycoprotein. It belongs to transferrin family. It is synthesized by exocrine glands and mucosal epithelial cells. It is released by neutrophils during inflammation, and the highest levels of lactoferrin are present in colostrum, and it is also present in vaginal fluid and cervical mucus plug. High iron concentration in the body fluids will favor microbial replication and formation of reactive oxygen species. Lactoferrin has got iron binding capacity, and thereby it reduces the free iron concentration in the vaginal fluid. Why probiotics for infection treatment? Because we are facing new side effects with the antibiotics, and there is a destruction of the normal vaginal flora and the antibiotic resistance due to abuse and overuse, and we are running out of antibiotics. And we are having a clear hypothesis about lactobacilli, and the application can also be topical. We can reach the high inoculum. Probiotics versus antibiotics. Antibiotics damage the commensal microflora. It can increase the occurrence of resistant bacteria, and it can have adverse side effects. Whereas probiotics can be used in adjunct to the antibiotics to restore the commensal microflora. So the ideal treatment should be, we have to provide Indian genomic specific strain, that too vaginal specific strain. The maximum colony forming unit should be 10 billion CFU. We have got studies, and in 2014, Mastro Moreno has conducted a study. He concluded exogenous lactobacilli can re-establish the normal healthy vaginal flora. And so many studies have occurred from 1992 to 2009. They have used exclusively vaginal capsules of lactobacillus, and that have cured the bacterial vaginosis. Thank you. Thank you, sir.
Thank you very much, madam, for this
Thank you.
presentation. You have covered almost all the things related to very much important topic. So thank you very much, madam, once again for your valuable time in Skill Connect platform, and in the future also we will look forward for some valuable session with you. So thank you very much, madam, and have a good day.
Thank you so much, ma'am. It was a wonderful presentation. So we'll look forward to associating with you for again and again for such kind of programs. Thank you.
Am I audible, Surya?
Yes. So I'm closing the session. I'm ending the session. Okay.
Okay, thank you.